The Intercollegiate
Psychedelics
Network.
Hi guys, my name is Pärham and I'll be giving a talk called On Spasticity as a Safety Consideration following the intake of serotonergic psychedelic substances in people with spinal cord injury. So this is actually a paper that I've been writing during the spring about a study which I'll be talking about. So this talk is centered around this study that's been conducted during the spring, and that's likely, or hopefully, let's say, being published in the near future. So yeah, let's try this. 17th time a charm. I'll be starting with some background information on spinal cord injury and psychedelic substances, and then I'll talk a bit about the materials and methods and some about the results as well. And then I'll pick out some of the extra interesting parts of the discussion. And I'll conclude with the conclusion. All right, so regarding spinal cord injury. So spinal cord injury results in paralysis from damage to the spinal cord, which affects both the somatic and autonomic neurological function. And depending on the level of injury, with cervical spinal cord injury being or impacting virtually every bodily system. So the multifaceted impacts of spinal cord injury warrants interventions across multiple domains of health, including physiological, psychological, and social life domains of health. And while there exist these centers of excellence that offer this multidisciplinary care, they're still rare and very inaccessible to many. So it becomes advantageous to try to identify a single therapeutic that can act across multiple of these domains of health. So walking into psychedelic substances, these substances have been gaining a lot of institutional attention in the form of clinical trials as of lately, and the growing evidence base for these or for the therapeutic potential of these substances is robust, but it's still highly specific to the mental health outcomes. The serotonergic psychedelic substances that I'll be talking about are LSD, psilocybin, DMT, and mescaline. And they're called serotonergic since they exert their effect by agonizing the 5-HT2A receptor. In the case of spinal cord injury, psychedelic medicine has yet to be put to randomized clinical trials, although the neurotrauma that comes with spinal cord injury often increases the vulnerability to the mental health outcomes that psychedelic substances are currently being used to address in other populations. So along with this potential effect of converging psychedelic medicine into the multifaceted impacts of spinal cord injury, there also exists a unique potential for physiological benefits specific to paralysis. So if we try to combine the current understanding of the pharmacological mechanism of action with the cellular mechanism of action governing motor neuron excitability, we get a pretty sound physiological rationale of how spasticity might be a potential risk factor of psychedelic substances. And the current pharmacological understanding on these substances converges on the 5-HT2A receptor, which I mentioned before, which when agonized exerts the psychedelic effect known or that these substances are being known for. In the context of spasticity, however, novel studies has been showing that the 5-HT2A receptor agonists also increase motor neuron excitability in the spine, which could lead to spasticity potentially. So this leads us to the aim of our study. And with any new and unproven and experimental medicine, the first step of understanding the effect is always to establish the risk that they potentially constitute. So the broader purpose of understanding the risk of spasticity from these serotonergic psychedelic substances pertains to the fact that a comprehensive understanding of the drug development process is the ground, or sorry, a comprehensive understanding of the safety of these substances is a ground pillar in the drug development process. So that's the broader purpose of why we're doing this. And the specific aim of our study was to characterize spasticity after the self-administration of serotonergic psychedelic substances in adults with chronic spinal cord injury. So talking a bit about the material and the method of our study, this was a within subject repeated measure design. So as a statistical analysis, we used a one-way RM ANOVA. The clinically validated scales that we used for our participants to quantify their spasticity were the pen spasm frequency scale and the visual analog scale. So both of these scales were developed to augment the clinical rating of spasticity and provide proven self-report spasticity data. Sorry, I've been saying spasticity like 20 times during the last 30 minutes, so bear with me. Due to the sensitive nature of some of the psychedelic substances being classed as Schedule 1 drugs, the risk of exposure for the participants increased. So one way we tried to combat this risk was by decontextualizing the information provided by the participants. So we didn't require the context in which the illicit substance was administered or any really specific detailed information about the psychedelic substance that they administered. Coming to the demographic of our participants, we had a mean age of 40.2 years with a standard deviation of 8.1. The genders were, we had 20 male participants, 5 female, and 3 put down their gender as other. And regarding the level of spinal cord injury, we had 10 participants who recorded having a cervical level of spinal cord injury. We had 10 who recorded having a high thoracic, which is above T10 level. We had 6 participants recorded having a below T10 level. And then we had 2 participants who submitted unknown regarding their level of injury. Regarding the cause of spinal cord injury, all of our 28 participants reported having a traumatic accident as their cause. And the mean duration of our participants' injury was 11.6 years with a mean of 8.9 years. And regarding the grade, 13 of our participants recording having a complete spinal cord injury, while 12 had an incomplete, and 3 participants recorded unknown regarding the grade of their injury. Walking into the results, the primary findings of this study show a pattern of increased spasticity at peak effect of the serotonergic psychedelics, followed by a decreased spasticity 24 hours after the intake. So on the screen, we see the pen spasm frequency scale and the visual analog scale. So this pattern of increased and decreased spasticity was consistent across all 3 of our different validated clinical scales. And the results therefore supported the hypothesis that psychedelic substances induce an acute and transient increase in the risk of spasticity. If we talk a bit about the limitations and the strengths of our study, there were many. The design of this study was, as I mentioned before, a recall survey, so it required both recall and self-report. And with recall comes the inherent limitation of risk of recall bias. So if we talk about the drivers of recall bias, then it's unlikely that the participants were, fitting their answers to match a perceived socially desirable one. But recall bias is also driven by the amount of time elapsed since the event. And since in our study, the recall duration was an uncontrolled and variable, recall duration, this increases the risk of recall bias being driven forward. And also, the fact that the participants were self-reporting spasticity, which is a perception during a time of an altered state of mind that was likely influencing their perception, this also becomes a clear limitation. The effect of these substances on perception of time and visuals is well documented. However, there's less information pertaining to the effect of these substances on proprioception and touch. And these are the perceptions that are involved in perceiving a spasm. So therefore, there's a limited evidence base for us to speculate on the accuracy of the perceived spasticity in our results. So amidst these limitations, there were some strengths to the study as well. The study benefits from being the first of its kind in this field of medicine. So this paves the way for future studies on integrating psychedelic medicine into the spinal cord injury continuum of care. Another strength of this study was the consistency of pattern of spasticity across all three of our validated scales. So the reliability of the pattern across the scales is combined with a strong effect size and this high observed statistical power. So finally, while the study's relatively small sample size is counteracted by a high statistical power, the heterogeneity of the group limits the generalizability to certain subtypes of spinal cord injury levels. Talking about some clinical applications and future directions, if further efforts are directed at understanding the potential therapeutic benefits of these substances, a comprehensive map of the risk is always the first step to take in the drug development process. So since there's a near absence of empirical evidence in this topic, then any new knowledge about risk is an important contribution. And the findings of this study could also be applicable to people with spinal cord injury today who are self-administering these psychedelic substances. To conclude this talk, we had, this study, which to our knowledge is the first empirical data on people with spinal cord injury and psychedelic substances. It demonstrated acute and transient spasticity after the self-administration of psychedelic substances. So this robust pattern, which we found independently across all three of our clinically validated scales, it strongly supports the need to view spasticity as a clear spinal cord injury safety consideration after the intake of psychedelic substances. Thank you so much, and looking forward to if you guys have any questions.